My name is Fergal Monsell. I'm an orthopaedic surgeon at the Children's Hospital in Bristol. We cover a reasonably big urban area, but we're a level 1 trauma centre and we take trauma from pretty much the whole of the southwest of England. Now, paediatric orthopaedics is a spectrum, and from a professional perspective, some days when I go to work, I need to be this kind old duffer and behave in one way. And on some days, I need to be substantially more forthright and aggressive, because sometimes you need to do nothing more than use a plaster or nothing. Just kind words and advice is sometimes appropriate. But in some cases, maximum surgical violence is encouraged because some fractures require an aggressive surgical approach. And the purpose of this series is to provide information on paediatric fractures. In this episode, we'll discuss the management of paediatric femoral fractures, the shifting baseline. What you will hear is information about the mechanism of injury, treatment options, complications, and sensible alternatives where they exist. Now, the shifting baseline means that what is appropriate for this individual may not be appropriate for this individual or for this. So the shifting baseline is childhood physiology. You have to have some idea about how that changes to inform you about what treatments are appropriate or inappropriate for an individual age group. And so for femoral shaft fractures, the shifting baseline, in my view, is between 0 and 6 months, 6 months to 5 years, and 5 to 16. It's completely arbitrary. I've made that up because that's how I think about femoral fractures. This is a 7-month-old child with a mid-shaft oblique femoral fracture. And the reason I put that up is because it's a very important point to get over. If you remember nothing else, this is what I want you to remember. Because a femoral fracture in a non-walking child is very concerning and has got a high index for non-accidental injury. This is one of the best papers on likelihood of individual fractures being due to a deliberate mechanism. And in their paper, there's about a 40% chance of a femoral fracture in an under 1-year-old child being due to abuse. And so it's difficult to conceive a mechanism in a child that can't walk. And you have to find a cogent explanation for a fracture in this age group before you move on. And in non-ambulant children, it's very difficult to fracture your femur. And so for 0 to 6 months, the two main devices that are used are either a Paediatric harness or gallows traction. And if we look at a Paediatric harness, it's actually quite a good device for managing femoral fractures. If you watch children in Paediatric harnesses, shortly after application, they're feeding, they're comfortable and they're calm. So the advantage is it's a very simple method of treatment. It is also very cheap because the patient can return home almost immediately. It doesn't require sedation. It requires a skilled practitioner to put a harness on without annoying the child or the parents. The disadvantage is it is uncomfortable. It is a fracture. It will feel it's just that they can't articulate it. So gallows traction, again, is used not uncommonly, and this basically is tying a child to the bed using gravity to manage the fracture whilst it becomes sticky in the early stages, and then you can do something else, usually a plaster cast. There's nothing in any part of orthopedics that people can't decorate with science. But in this particular example, it's basically as you raise the legs, the perfusion pressure is altered. And if you have a heavy child with their feet in that position, there is a risk of distal ischemia. So you have to be thoughtful when using it. And so my guidelines are about 10 to 15K, provided with that I can get one of my hand under the buttocks. I tend not to use it because we either use a Paediatric harness or immediate spiker. But for the very small kids, it's a very useful way out. Some people use a gallows for a period of time to, in inverted commas, allow the fracture to get sticky before putting it in a cast. And that's another point for discussion. So the 6 months to 3-ish years is a hip spiker. But I don't think it's suitable for very axially unstable fractures. So if you've got a high energy comminuted fracture, it's probably not the right thing to do. But particularly, and this is from my colleague, Mr. Hunter, he doesn't use spikers in children who can answer back. And I think that's really him just saying that there is an age consideration. Up to 3 years old or thereabouts, I think is a perfect indication. Some people go up to 5 years, which I don't have any particular difficulty with. And the advantages of that is the short hospital stay. Our mean stay in hospital for a femoral fracture in this age group is 1.5 days. And they come in, they go on the next available trauma list, and they go home that day. And it can be a day case procedure if the family are enthusiastic about that, or an overnight stay whilst we make arrangements for them. It is relatively inexpensive, but it does cost a day in hospital, a trip to the operating theatre. Disadvantage is that it requires a general anaesthetic. You have to put these on properly. You cannot do it on a awake child. and you have to know what to do. And so abdicating this to someone who's never seen a hip spiker and saying just slap one of those plastered trousers on, I think is missing the point completely. And the person who's applying the cast has to have experience in doing that. It's written down in the AO surgery reference, and there are step-by-step descriptions of exactly how to put a spiker on for trauma. The risks are pressure sores. If you do not pay attention to detail and you throw this on without proper padding, as with any cast, pressure sores will be a potential problem. And compartment syndrome is often talked about. I've never personally seen it, but it was written up nearly 20 years ago in the North American literature that on day case application of hip spikers were associated with a small series of compartment syndrome, but with devastating consequences. This is a typical picture of a boy in a spike. He's got quite a good use out of that. I've seen children ride bicycles with a one-legged spiker. It takes the parents about 3 or 4 weeks before they get used to it, and then it's time for it to come off. But it's a very effective way of looking after these children. In the 5 to 15 group, the options really are flexible nails. 5, anything below 5 is a little bit small. Anything above 12, you're probably missing the point, and we now have better inventory. You can plate any femoral fracture. There are some relative indications and contraindications, which I'll come to. And conventional nails, piriformis entry nails, I think you should probably not be using in paediatric practice for reasons I will try and convince you of. And so again, this is a technique which you should be all able to independently conduct before you start consultant practice. It is relatively straightforward, but there are points of detail that if you understand them, it will be much more straightforward. It is a very easy procedure to do badly. Nail size, rules of thumb, the diameter divided by 2 minus 1 millimeter. You're going to want to get a 75 to 80% fill of your narrowest part of the canal. And so you can basically work it out. But as you get bigger nails, they get much stiffer and they're hard to pass. And so it becomes a bit of a compromise. There are a number of sizes. The advantages of a big nail is its stiffness, and the disadvantages of a big nail is its stiffness. So it will be stable but hard to insert. And so there is a compromise. And also you have to contour these nails so the apex of the convexity of the bend in the nail is at the level of the fracture. And that will be a pair of equally sized, symmetrically contoured nails that when placed within the bone, that maximum contour is at the level of the fracture. That's quite hard to do and take some practice. If you don't do it, you can get away with it, but sometimes you'll introduce deformity if you either incorrectly contour your nails, but particularly if you use nails of different sizes. You will almost guarantee introducing deformity if you don't obey that one rule. So if you forget anything else, the nails have to be the same size. I've seen people try and do this through a stab incision. Well, they clearly don't understand that someone's got to take these out. So my instructions are you put the nail in through a taking it out incision. But by doing that, it allows you proper visualization of where you're putting it. And so I want the nail to enter approximately 2 to 3 centimeters proximal to the physis. So I want a gap there because I do not want any physeal damage either during introduction or a pressure effect of the nail laying on the perichondral ring at the point of insertion. So I want a decent skin incision. So 2 centimeters will allow you to get retractors in, and you can retract muscle out of the way until you see periosteum. And then when you can see that, it becomes much more straightforward. I've seen people sticking awls and drills blindly in and then wondering why, first of all, that they skid off the bone, and second of all, why they can't find their holes. I hate this instrument. I've got this theory that if it's going to slip, it will always slip in the direction of the structures you want to protect. So in the femur, if it slips, it will slip posteriorly. And in one move, you'll have taken out the popliteal artery and a bunch of nerves as well. So I don't use this. I use a drill that's 0.5 millimeters greater than the diameter of the nail. And then I expand it as I put it in. I put it in with the shallowest angle possible to give me the best chance of passing the nail past the far cortex. You then got to cross the fracture site. Tips of the trade, really, if you put both nails in first, that allows you to control one section. You can put traction, you can change the orientation of the distal segment, and there are tools that come in the nailing kit that allow you to manipulate the fracture in the AP and the lateral plane. If you think about what you're trying to achieve, which is to thread a steel rod through 2 parts of a hollow bone, how hard can that be? Well, it actually can be quite difficult sometimes. So you need to set in your own mind a time limit after which you will not attempt any further closed reduction. And it depends on how I'm feeling, but it's about certainly no longer than 10 minutes. If I can't get a nail across the fracture within 10 minutes, it requires a small open approach so you can do a direct reduction. I see that as an understanding of technique rather than a failure of technique. Complications, any operation has a risk of infection. Nail migration, particularly if you put a distal nail in, it migrates distally. You can get skin irritation and skin perforation. You can get knee stiffness because they do irritate the hamstrings and the quads. Non-union and malunion are rare, and they're usually when they're incorrect sizing of nails or incorrect patient. The conventional weight limit is 50 kilograms. Anything more than that, you probably ought to have a different device. And if it's a 50 kilogram younger child, plating is a good option. If it's a 50 kilogram older child, then some form of lateral entry nail. So plating, it's gone out of fashion, but it is an excellent treatment. Before the introduction of flexible nails, and when I was training, all femoral fractures over the age of about 5 were plated. It gives you a consistently good reduction, alignment, etc. It's very good in a multiply injured patient because you do not want to be doing your first flexible nailing in a patient that's in extremis. And if you've got someone who's very, very high tone after a significant head injury, you may find that you lose position with your nails or they're uncomfortable because of the muscle tone. And it's quite a good indication for plating. The inevitable downside, it's a scar. It's a big scar. There's a lot of muscle stripping. There is probably an increased risk of infection. And then you have to retrieve the plate and there is a risk of subsequent refracture. But that is a list of complications that's common to pretty much any trauma procedure. A better way of plating it is submuscular plating for a distal femur. The anatomy is clear. You just go under subvastus approach. The plates are Paediatric femoral shape, and it is a relatively straightforward procedure to undertake if you're used to using locking plates. And so that's one procedure I think you should be on top of for paediatric practice. In the older child, femoral shaft fractures are a worry because the fracture pattern almost demands an intramedullary nail. You look at the vascular anatomy of the proximal femur in a prepubertal child, sole blood supply of the femoral head is as shown. And so if you want to think about where you're putting a piriformis entry, which is about there, and by the time you've reamed it, you've probably taken out the vast majority of the blood supply to the femoral head. And that is a worry because avascular necrosis in an adolescent hip is a life-changing complication. And there are case reports of AVN following femoral fractures, which led us to go away from that. We just did not want to use the nails that were present at the time. The best study looked at 1,600 fractures and found about a 1% risk of AVN using conventional entry nails. So that led to lateral entry nails, which is now pretty much mainstream practice for adolescent femoral fractures. And the tools that we've got, irrespective of who provides them, will allow you to most of the length of the diaphysis with recon options for femoral neck fractures. And that's another technique that I think is a very good one to master. I think I need to give you alternatives because there are a few fractures that demand an operation. And a closed, uncomplicated femoral fracture is not one of them. It's just the economic imperatives of keeping someone in hospital are huge. And if you are suggesting to someone that they have to remain in hospital for 6 weeks or more, whilst parents have to work, children have to go to school, it's just not something that most people could, in their wildest dreams, accommodate. But occasionally it's happened. This is a patient who, for a variety of complex reasons, their parents absolutely refused any surgery at all. And even to the point of not allowing me to put a traction pin in the bone, that was off limit. I wasn't particularly comfortable about it. I thought this is going to end in tears, but we managed her on skin traction for about 12 weeks. And you know what's going to happen because otherwise I wouldn't show it. And she was absolutely fine. And so it just labours the point that you don't have to operate on anything. The options that I've given you for each individual age group, I hope, are sensible, reasonably clear. And I think that because this is something that you will be required to manage on day one of your consultant practice, it's something you should have a plan for. Everything I've just said to you is written down in that article. It's the European Journal of Orthopaedic Traumatology. If you have suggestions for future material, please feel free to contact us at the Grand Academy at btinternet.com.